Okay, welcome everybody, and welcome to Giant 2024. If you are hoping to be here to listen about ICSs, digital and tech in ICSs, you're in the right place. If it's Future Hospital, it's the other end. Okay, so welcome everybody. I'm going to do a quick intro. I'm Rima McCarran. I currently chair Bedfordshire, Luton and Milton Keynes Integrated Care Board. And I will be chairing this morning, as well as chairing the very first panel. So for those who may be new to the NHS, this has been quite a whirlwind time for us with the creation of integrated care boards. They were created so that we could do more beyond the NHS for the population's health. So ICBs, or ICSs, are the partnership set up as legal entities between the NHS, local government, the voluntary sector, charitable sector, and even wider partners such as fire, education, health, police. And it's all centred around the population and the citizen, so a lot of engagement with the citizens. They're only 2.5 years old, so they're toddlers at the moment, but they've had a hell of a birth and a hell of a babyhood. So they were created in the aftermath of the pandemic, when staff were exhausted and demoralised and the population was a lot less well. We hit the cost of living crisis, which of course made people even less well. So demand has gone through the roof for the integrated care systems and for the NHS and social services. In the meantime, although we have continued to increase the workforce in the NHS, activity doesn't appear to be at the same level as it was before. Lots of theories as to why that might be, including the fact that the people who walk through the doors of the NHS are a lot less well, need a lot greater intervention than they used to need. So why was it a difficult babyhood? So within 6 months of being set up, it was decreed that all systems had to cut their running costs by 30%. So that was already one big hit when you have to get rid of the staff that you've needed for your startup. The NHS, as you'll know, keeps struggling for money, but local government's even worse. They're really, really struggling. Many are now going bankrupt. And the voluntary sector with whom we work can't fundraise because there's a cost of living crisis. So they're really struggling as well. So the workforce itself, well, we know we've had almost a year of strikes. They want pay increases, not having seen any pay increases for many years before. So that's also been very tricky to navigate. And then, of course, we've had changes of Secretary of State and more recently a change of government. However, what's encouraging with the current government is that they are talking about the 3 shifts that we were set up as systems to deliver. So moving from illness to prevention, moving from hospital to more care in the community, and moving from analogue to digital. And this is all great news because that now aligns with the strategies of most of the integrated care systems in this country. But how do we balance the pressures of today, getting through those elective waiting lists, getting more people to see more GPs or other primary care professionals, and how do we marry that up with wanting to invest money we don't have into more tech and prepare for the future? So that will line us up now for our first panel. So I'd like to welcome to the stage Jo Harrison, who is both the CEO of Milton Keynes Hospital, but importantly, the NHS Director for NHS Digital Channels, including the NHS app. And also Max Jones, who is the Chief Digital and Information Officer at one of the Northern ICBs, and also the Managing Partner for Technology at Agilicis. Welcome. Right, so welcome to you both. I wonder if you could kick off by giving us your vision of where digital and technology could take all our healthcare systems over the next 10 to 15 years. Who'd like to kick off? Joe.
I'm happy to go first. So my vision is that we fundamentally change the NHS model of care. Aim high and make sure we deliver. The nice thing about the position I'm in is that I get to talk about the most successful IT project the NHS has ever seen, which is the NHS app. and we've only just started now. I presented to the NHS England board in January that we would see a third of all transactions between the citizen and the NHS be digital within 5 years. My expectation is that we will exceed that. My expectation is that we will take the current health inequalities that are endemic within the current NHS provision and enable those that can to manage and support their own healthcare and illness, and for those that aren't able to, we will enable them to access the NHS in a way that enables them to own their conditions where they can and be managed and supported where they're not able to. Imagine a world whereby we allow our patients to access outpatients on their terms, not 9 to 5, Monday to Friday. Imagine a world whereby the citizen as we know them today is the one that determines how they access the NHS, either going to their GP or turning up at the emergency department. Imagine that we provide them with those pre-primary care diagnostics that allows them to determine where best to turn up. They're using their wearables to enable them to establish their health and also to see where they are unwell. I'll finish by saying that in October we had 55 million logins to the NHS app. Nearly a quarter of the entire over 13-year-olds in our country signed into the NHS app. And we don't even really have any wellness and health elements in the NHS app. So it's a staggering number. Our citizens want it, and the NHS can provide it. Thank you.
Thank you. Max?
Thank you very much. The good news is I totally agree with Joe. Actually, this is all about empowering our citizens to take more ownership of their health and care outcomes. And to do that, we're going to have to challenge a whole load of the ways that we work inside health and care. And coming, as I do, certainly part-time from an ICB, a lot of this focus is not just on the health, but also on local government, police, education, and its impact on the way in which we support citizens. Now, to do that, I think we're going to have to start thinking in an integrated care way. We know that 80% of the determinants of health are not actually health. They're about other factors. It's education, it's policing, it's housing. And therefore, it seems to me that to get the health system operating successfully, we actually have to get the whole of integrated care operating successfully. So I'm delighted to spend the majority of my week supporting the Integrated Care Board in Humber and North Yorkshire. At the same time, I spend my other 2 days a week thinking about generative AI, how artificial intelligence is going to change society, and what that means for the sorts of things that the NHS needs to do. And in doing that, we rub up against all sorts of interesting challenges about innovation, risk aversion, the policies that we need to put in place from the centre that are going to give us ways of enabling that cultural shift inside the care delivery services. And part of that fundamental challenge, I think, is going to be about the relationship between citizens and their carers. And I think, historically we've had a very paternalistic relationship between carers and the citizens. Actually, as we enable citizens with the sort of tools that the NHS app is providing, but others as well, access to their information, I think they will become a more empowered power for improving the health of our nation. So I see a rise in citizen impact on health, and I think that's super important. I suppose the one other major shift I'd flag is probably that I think for the first time in human history, computers understand free text better than humans. So one of the other enablers for this 10, 15-year vision is that we stop forcing our excellent caregivers both to do enormous amounts of administration. I'd like to see that automated and augmented, but also that we start to shift to free text as the language of care, that we move away from the artificial coding of information and we move into an ambient transcription, a collected data, which is then used for both primary and secondary purposes. and we should be able to refine our models of population health management, which again talks to the role of integrated care boards.
Thank you. So if I ask you both, you talked about, Joe, digital exclusion. You've talked, Max, about tools that will enable the workforce. What do we do to help both the workforce and the citizen to start taking care of health, their own health or others, through digital tools? How do we get over that exclusion and that divide?
If I start, and I should say, if there are people at the back that want to come forward, it says reserved on the seats, but feel free to take them. So how do we enable our citizens? The first thing for me is to make sure that we don't go to a point of only having digital access for the NHS. I think as soon as we get to that point, the Ryanair point, as I like to call it, I think we've failed, because we know that there are 7% of our population that don't have smartphones. We know that there is a proportion of our country that doesn't have access to the internet and so on. So we have to keep the dual model available. That's the first thing. Second thing is, I think we need an honest conversation with our public about the health inequalities that our current NHS has. So at the moment, we expect you to access the NHS for any planned care almost entirely between the hours of 9 to 5, Monday to Friday. We write to you in English, by letter, and that absolutely excludes another big part of our population. So let's celebrate some of the benefits that our digital world does give to the NHS, and let's open up the NHS to a 24/7 service that we don't presently have. I think the final bit for me then is, we term hard to reach some of the groups that aren't able to access digital. That is utterly incorrect. They are not hard to reach. They are individuals that we don't make enough effort to go out and find and engage with. So whether it's, as we've done with the NHS app, to enable people in libraries to teach people and help them out when they come in to use the NHS app, or whether it's one of the interesting proposals that I've heard about how do we engage our school children in a way that enables them to learn now what their digital health future will be over the coming decades. And I think there's a lot to be said for engaging and making sure that our under-16s know how to use this technology.
So not surprisingly, I agree with all that, Joe. But also, I think we've got one of the benefits of an integrated care board, I think, is understanding the needs of your population. So if I represent Humber and North Yorkshire ICB, a large coastal elderly community, lots of deprivation, an unusual ethnic mix in some of our cities, wide disparity between some of the regions that are highly affluent, some of those that are extremely poor. And we also have to have a very targeted approach at place or integrated neighbourhood team level, so that we're focusing the resources in those things that will make a difference in all areas. I see, in terms of digital inclusion, the world has shifted from where we were 5 years ago. We were talking about, are we giving out devices? Are we doing Wi-Fi? That's no longer the challenge. It's not really a technology challenge. It's about enablement, it's education, it's about understanding communities. The other thing I'd say is, from a strategic perspective, we, as the NHS, not necessarily as ICBs, but as the NHS, we love a strategy. And those strategies tend to look beautiful. If you're lucky, some consultants have written it, and it's lovely colours, and it sits on the shelves and doesn't do anything. Actually, I'm going to make the case for a strategy that I think we need, which is a customer strategy. So I spend quite a bit of time both with health but also with local government colleagues. In local government, certainly in one of the local governments I'm working with, they've created a customer strategy, and the customer strategy says, we wish to engage with our citizens and provide these services. These are the ones we will do digitally. These are the ones, if you don't want to do digital, here are your other routes to access those services. Much to Joe's point, this is not about digital only. It may be digital first, but we have to enable everybody to get great care. So I think we've actually got a missing strategy at the moment. Won't surprise you, I've started work on one for Humber and North Yorks. We don't have one yet. But to think about what is our vision going forwards, and then we can line partners up behind that, whether they're in health, whether they're in other public sector bodies, and we can start to give the citizens some of that access and some of that control that we've talked about so far.
So, good vision. We all agree, I'm sure everybody in the room agrees, that we need more digital, more AI to change the face of healthcare. How do we start pushing forward, given all the pressures of today? How do we do that balance? Max, do you want to start?
Yeah, I'm very happy to. Actually, we won't have any choice. I think if you ask, how many people are using generative AI in the last 30 days? I run workshops for healthcare leaders. In one that I ran last week, we had about 80 people. In a survey of how many of you have used generative AI in the last 30 days at work, it was about 3/4. And I think people have a view that not only do our leadership not use these tools, but our citizens don't. Actually, most of our citizens, most of our healthcare staff are using these kinds of tools on a daily basis. We have to reflect that in the way that we write our AI policies, about our expectations of what citizens are doing. And I think rather than what do we need to do to enable it, I think actually people are going to start using these tools whether we like it or not. Now, they're already doing it inside our health system, but if you've got access to a great set of records about your own care through the NHS app, and I'm a massive supporter for the NHS app, then citizens will be able to download that data, to put that into tools that they want to use, and we'll come out with conclusions. And some of those tools will be great, and some of those tools will be less great. So I think the emphasis for me is it's partly on what can we do to meet the need, but actually the need is coming at us, and our customer expectation has shifted massively, I think, in the last 2 years. So we're on a bit of a catch-up.
From my perspective, I think there are three things. Firstly, let's be honest about the current health service. We've got 7.5 million people on our waiting lists. We know that they are waiting for procedures and tests and outpatient appointments, and that is an unacceptable position to be in, and we have to reduce that. So there is currently a problem, challenge, difficulty, whatever word, politically correct word that you want to use. Our NHS at the moment is not able to cope with the demands that our patients have got. So let's be clear about that. Then let's be clear about the fact that we know that there is risk within our current system that we aren't explicitly acknowledging when you go and see a professional. Whether that is a GP, whether that is a surgeon, we know that there is AI technology that is available that is as good and in some cases better than the clinician in front of you. Let's be honest with our public that that is the case. And then finally, for me, the risk appetite of NHS England, the Department of Health, and indeed organisations like mine is critical to making this work. If I'm looking to innovate, I can't then sit back and say, I'm going to do a 2-year study, prove it to me, and I'll come back to you and procure it in 3 years' time, because the world will have moved on completely by then. How do we enable organisations like mine, NHS England, Department of Health, to say, we're going to implement this medical technology, we're going to implement this AI, because we believe it is as good, if not better. Rather than at the moment, the challenge that we have is, can you prove this technology is 100%? And the answer to that in most cases is going to be no, but we can prove it's better than what we currently have. And finally, just on that, this is about enabling our clinicians to have the headspace in the room to be even better than they are. It's about taking away tasks from them that artificial intelligence can do. It's about enabling them to use the circa 10 years worth of training and education that they've undergone to bring that holistic and rounded approach to the management of the patient, which we know that AI isn't there yet and won't be for a number of years. So it's not about replacing the clinician, it's about enabling the clinician to add even more value.
So if I follow on from what you've said, we know just yesterday or today, Julian Kelly, for example, has said we need to save money, we're going to cut our support staff. How do we get that shift in mindset at the top, whether it's NHS England or our politicians, to support the arguments you've both put forward about the need for digitisation, AI, and changing the way we do things?
So I'm going to reference, I suppose I use... Sorry, can you hear me? Yes. it's an interesting dilemma here, isn't there? So we struggle with the priorities of today and the priorities of tomorrow. And most of our effort, I think, as humans, most of our effort goes on sorting out where we are today. What are the current tactical issues? What's the immediate stuff in front of me that I have to deal with? And they will always drown out the opportunities to think about the strategic. One of the things that I'm most impressed with that they've done at Humber in North Yorkshire is to set up something called a Futures Board. So that's a subcommittee of the ICP, which is chaired by an external academic, but his focus is on what are the things that we could work on today that will have a benefit in 3 or more years' time. They are not allowed to think about the things that are in the immediate. And they've spent their time as a group of adjutants. So they've got academics, they've got industry, they've got innovators, they've got health, they've got social care, across the board, thinking about what we can do in the future to make a strategic difference. So they're focusing on, and I'm delighted to be a part of that board, but they're focusing on children's health on the grounds that children they're our future citizens. Let's get them educated. Let's deal with their family challenges. Let's deal with their health outcomes and prioritize what we can do with data and with technology. So I think there are probably some structural things which we can do as NHS bodies and integrated care bodies in making sure, and Joe, you talked about the mental bandwidth and the space to think. I think we have to carve that out not only on the front line for our clinicians, but also for our boards and our executives and our strategy holders to start thinking about things we can do that will make a massive difference in the future.
I absolutely agree. I think the other thing is Julian's right. Julian Kelly, as the CFO for the NHS, has to challenge how we spend every single pound. Okay, let's just be real about this. One of the big things that I would like to see happen over the next couple of years is that we want to actually start to stop doing things. And that for the NHS is going to be a really big challenge. So last year we spent between 450 million pounds on sending text messages and letters. Come on, folks, it's the 21st century. We're still doing it. You put a message through the NHS app, it's free. If there are people sitting in this audience that have not got their notifications on and have not turned paperless on the NHS app, then have a word with yourselves, because actually you're costing us money. And moving to a point whereby we're spending taxpayers' pounds appropriately is absolutely the focus. I grew up as a medical records clerk. I am absolutely clear in the future medical records clerks won't exist. There won't be a medical records library as we knew it 30 odd years ago. However, I also know in places like Milton Keynes, I'm really struggling to compete with the likes of Amazon, with the likes of all of the food outlets, the M&S and the Waitrose, on low-paid or low-skilled jobs because they're being taken by the private sector. And actually what I want is a workforce that stays with me, that I can develop and I can train, and I can get them using the latest technologies to make their jobs as interesting as I can and have them contributing as much as they can.
Okay, thank you. So last question, and then we'll open it up for questions. So you've both talked about digital transformation. To deliver it, who are you looking to partner with?
So from an NHS app perspective, there'll be, I'm sure, lots of companies in the audience going, if only I were on the NHS app, I could save the country millions, if not billions. And many of you may well have a point. We are at the stage of development. For those of you that read the HSJ, you'll have seen Paul Corrigan come out at the weekend to say, if you aren't prepared to integrate with the NHS app, then we aren't prepared to consider you as a supplier. So from my perspective, that is a number one priority for all of the suppliers in the room. Number two priority alongside that is how do we engage with our citizens so that we put the right technology in the right form in the NHS app. At the moment, everything that's on there is readable for an age rating of 8. We've just made the NHS app able to speak to people, so those of our citizens that are blind can actually hear what's being posted on the NHS app. We've got a 38,000 citizen panel that we engage with. The more that we do that, the more likely we are to come out with an NHS app that's just not fit for today, it's also fit for tomorrow. Those are the two big ones.
I suppose it's easy as a techie to think the answer's technology. I think my partnering comment would actually be about bringing together the innovation and improvement world to actually make the best of what we've got in technology. I think actually we have an enormous number of really capable tools that are coming to being, that are based around the NHS app increasingly. What are we going to do with it? And how are we going to transform our care services? So I talk about citizen at the centre, multi-agency pathway transformation. What is the vehicle for doing that within a region? How are we bringing together and educating people and giving them the freedom to go and do improvement exercises, to fail fast, to have risk appetites? Joe, you talked about moderating our risk appetite for these things. And I actually see the future as being limited more by our ability to adopt technologies and innovations than I do by the technologies and innovations themselves. So I would say my partnering ask or my partnering push is actually around that improvement element. And when we know we've got NHS Impact, but what are we doing to give everybody the freedom to try something new? And as long as it's better than it was before and you can evidence it, is that good enough? What are our tolerances for risk? And I have to say, the other people I'd love to partner with are our regulators. It is with one foot in the supplier world and one foot in the NHS world. It is incredibly difficult to deliver software and understand whether you're a medical device or not. And I think if I'd got a request for our Lords and Masters, it would actually be to make that process a whole load more transparent and straightforward, because it is not helping us to understand the levels of risk that we're taking when we adopt tools and technologies.
Thank you both. So at this point, over to you. Any questions? Okay, gentleman here. Hang on, sir. Is there a...
Can you give examples of what generative AI tools are being used by the clinicians and by the hospitals?
Sorry, can you do that again?
It's a question for Max. Can you give an example of what tools, the generative AI tools, are being used by the clinicians and case managers and nurses inside the NHS Trust?
So that's a great question. So I think we've got a variety of things, both the things that are here and now that we know about. So we know that lots of people are going to use Copilot, and actually, the Copilot environment, if you haven't used it, has come on massively in the last couple of months. I think we will find its availability on everybody's desktop a massive draw for people to use those, and we probably can't imagine quite how many ways those are being used at the moment. I see ambient dictation as being probably the most promising generative AI technology that's available, where we can start to have what I'm hoping is it'll empower citizens and carers at the same time, so that the citizens get a fuller transcript and record of the conversation. So if I'm an elderly citizen and I have my bad cancer diagnosis, I've got no idea what was said. I go home, my kids can read it to me and go, "No, Dad, you got that wrong. This is what's happening." So I think some of those things, you can see how that could integrate with the NHS app. You're giving tools to citizens, you're giving access to information to citizens. But I think as we go further forwards, I kind of touched on it earlier on, I think we will see the rise of free text. So if you look at the latest tools that allow you to query databases using language, I think that will shift the sort of democratize access to information for policy, for strategy, and for continuous improvement. And then I think we'll see free text transform the way that population health management takes place. So instead of it being very structured and, I spent 30 years building relational databases, what fun that was, it's about to shift, I think, and we're about to see free text become the most insightful piece of information we've got. So getting access to all that free text that's locked away in our systems. I also see in those conversations, I see a lot of insight, probably in social care and mental health, where in the past we've viewed those as being a little bit less advanced on their digital platforms. Actually now I think we're going to come to see those quite rapidly have the richest form of free text in their historical records, because they were largely there for patient care, and we'll see that take off very quickly as well.
is there a risk that they're uploading patient information into Copilot that's being stored offshore, and how are you planning to tackle that?
So it's got to be a risk that you have to take seriously, and I think whenever you're deploying AI, you have to make sure that you're doing it in a safe and sensible way and that there's a degree of transparency. I think from what I've seen, Microsoft have gone quite a long way and been really clear about where their data's held, what purposes it's used for, and when information gets transferred or not into a public domain. I personally feel quite comfortable using Copilot inside Office in my NHS tenancy, and using that for sensitive information that it isn't getting bled elsewhere. But each organisation's got to go and make its own assessment of those. But the information is out there to assess it. I think it's come a long way.
Thank you. Can you pass it to the gentleman just behind you? Thank you.
Hi. Two quick questions. One is that coming from the clinical background, I have seen that whenever we are trying to implement a new technology, there is a lot of, I won't say resistance, but there's a bit of inertia, especially the senior clinicians. Because say, for example, a very busy surgeon would just like to write fit for discharge rather than going through a template, which takes 5 to 7 minutes. So I know that we are emphasizing on the education to the general populations. Are we also targeting clinicians that we are so much used to, that old paper and pen form, that there's a bit of a resistance there?
If I take that, so the delights of being a chief exec of Milton Keynes is that I see some of that resistance. And what I would urge is that organisations, teams, focus on the 80% of those individuals that do want to try it and do want to get involved, or indeed are ambivalent, and those 20% that are utterly resistant do come along. They do come along eventually. There's no harm in being a late adopter. There's no harm in wanting to see how things play out. And I think that's completely acceptable. What we mustn't allow is for those 20% to drift off and never engage. And I think that's where the NHS has a bit of work to do. We see it nationally around, we have GP practices that have got a 9% adoption of the NHS app. Now, some of that will be technical issues, I'm sure, but some of it will be the GP themselves not enabling the citizen and not helping the citizen to engage. So I think there's a test there. Focus our energies on the 80% that want to.
Can I come back on as well? So one of the other things I think is we have to recognise it takes time. So if I think about, I look after innovation research improvement for the Humber and North Yorkshire region, and one of the examples that we had was about 2 years ago. We had an orthopaedic surgeon who was recording videos after they'd done the surgery and putting it onto the patient engagement portal. And it has taken the concerted effort of a team of people to get that rolled out. It is phenomenal. The evidence of reducing follow-up, improving, citizen outcomes is utterly amazing. But even when the technology existed, even when we'd got, a senior clinician advocating it, it required a team of innovation advocates to get that rolled out, to put the effort in, to see the spread to other specialties, and to see it spread to other organisations. So it's going back to that cognitive bandwidth thing for me. We're all humans. We like to do the same stuff we've done all the way along, and change is hard. So I think we have to put effort into supporting that change, even where the technology's proven.
Thank you. More questions. I'll pass over to the lady over there. You had your hand up.
Well, thank you. Thank you so much for the discussion. I had a question for Joe. I just wanted to ask, what are the current technological challenges that you're currently having?
I'm really sorry, I'm struggling to hear with all the background.
No worries. Can you hear me now?
Yes, that's perfect.
What are the current technological challenges that you're facing with the NHS app, and how do you see yourself overcoming them?
What are the current technological challenges of the NHS app, and how do we think we're going to overcome them? So the first thing for me is speed of regulatory approval, sign-off, and implementation. So it takes a good year to get a business case through all of the regulatory bodies before we can start the implementation in the NHS app. And that includes Treasury, and that's not a criticism. It's a difficult business running government, and we've got to get that bit right. So that time frame is long in the technology world. I think the second thing for me is it does come back to, is better good enough? And do we have to, for example, where there's proven tech elsewhere in the world, do we have to run our own 2-year longitudinal study in the UK to then enable that technology to come into the NHS app? And my view on that is I trust a number of other countries who have done these studies and used same methodologies to enable that to be reflected in the UK market. I think the final thing for me is, and it comes back a bit to what Max was alluding to, is it's not really the technologies that I think that are stopping us. It's the consistent implementation of those across the country. So how do we ensure that every single GP practice, every single secondary care institution, every single supplier, every single citizen that interacts knows how, understands the rules of engagement, and if they don't, they are then enabled to understand them, and we do things nationally rather than in different pockets around the country. Those are the big things for me.
Thank you.
Thank you. The gentleman at the back.
Hi, Joe. The improvements in the NHS app have been fantastic over the last few years. How do you see the app being able to both ensure that patients sort of get the care that they need and they are eligible for, but on the other hand, how do you see the NHS app being able to reduce the amount of fraud that happens in the NHS when you have maybe about 1.3 billion of fraud? And if an ICS was able to tackle that, it would be about 25 million an ICS. So how do you see the NHS also being able to potentially address the issue of fraud?
There's a question I've never been asked before, but in terms of the sort of first point, I'm just trying to think. Fraud for me is something that is almost certainly not at the top of the agenda for the NHS app. Enabling the citizen to make an informed decision about how to access and when to access the NHS is. So the more that we can open up the clinical information to the citizen, the more likely we are to both empower that citizen, enable that citizen, and also to enable that citizen to be the final safety net. And I know people don't really like talking about this, but we know that NHS hospitals and GP practices do occasionally lose patients in the difficulty that is patient pathways. Hearing on the BBC that a patient found out that they had cancer because they looked on the NHS app, for me, is one of those moments where I'd rather they found out by looking on the NHS app than not finding out until they present in the emergency department with stage 4 palliative treatment. So actually, for me, it is about empowering the patient, and it is about giving them all the information that they need.
Yes, the gentleman over there.
Thanks, Joe. I agree with you. We can't wait 2 years for some of the evaluation for some of this new tech. What are you doing in your trust? What hints and tips have you got for speeding up the adoption of some of these tools?
So I'm going to do my best impersonation of Joe at this moment while he thinks about that. So I think from an ICS point of view, creating a culture of innovation and adoption is, I think, probably the most important thing. Thinking about how we get the adoption of these technologies, how we train people in, running experiments, doing before and after measurements, looking at the evidence, creating communities of practice, actually requires a significant amount of effort. And again, going back to the point that is, you'll only get the value out of these things if you invest in that change management, the innovation improvement piece of it, as well as the technology. So I think that's probably my major request. And the other point for me is probably also recognizing that we have some untapped areas of our health and care system that we're probably not making the best out of. So I had the pleasure of visiting a couple of really innovative pharmacies community pharmacies last week in Scunthorpe and Grimsby. Fantastic places, but hampered in their ability to interact with citizens. And I think there are real opportunities for us with the NHS app, but also with other technologies that we provide, to put citizen at the centre and when we do these design decisions, because we are. There's a wonderful quote, isn't there, that all complex systems were simple systems 20 years ago that we've enhanced continuously for 20 years. And I think in a number of ways we've developed that in the NHS. So I think paring it back, but thinking about all the different agents.
And in order that people don't think I'm trying to avoid the question, from an MK perspective, there are, I think, 4 stages that we look to for whether we go with things or not. The first is the product actually trying to solve a problem we've got? It's amazing how many products are out there that are solving problems we don't have. I think the second thing for me is, do you have confidence, credibility in the supplier team that is in front of you? And how do they present? What do they look like? What's their goal in getting involved? Thirdly, I've mentioned it a couple of times, is the technology standalone or is it integrated with the systems that the organisation has, and indeed nationally we have? And then fourthly, and most importantly, and they have the stop-go decision, which is if it's anything to do with a clinician's pathway, clinical team, that team has the absolute right to say, I don't care if it's brilliant tech, I don't care if it's this, I don't care if it's that, it's not for us. So I think those 4 stages are how we do it. We absolutely get it wrong in Milton Keynes, no question about that. I've made a career of it. And it is then, how do you accept failure as well? So do you go out and say, that's outrageous, we're never doing that again? Or do you accept that innovation has failure risk and move on?
Thank you. We've got a question just here at the front bit.
Question for Max. In terms of cybersecurity on the ICS level, where do you see the role of the ICB, ICS in adopting cybersecurity technologies?
Interesting question. I think one of the biggest things we've done is to establish the right levels of governance and to give us insight into where we are with our current footprint. For me, things like multi-factor authentication, super important. Things like having the MDE, Microsoft Defender, rolled out across all devices, super important. The obvious one, it's less glamorous, but the obvious one is make sure your business continuity disaster recovery exercises exercise you as a system. So all of your individual providers of care will be, thinking about their own business continuity. But I think when it comes to cybersecurity, the question is when, not if, you're going to get attacked. And it's how do you respond? How do you detect? How do you cope with it? So I think the ICB definitely has an oversight role, but also a bringing partners together to make sure that they're ready in the event that things go wrong.
Thank you. Could you pass the mic yeah, thank you.
Hi, thanks for the talk. Just following on from the last but one question, we've talked a lot about increasing the appetite for change and adoption of technology from a provider and an ICB perspective. But from a supplier perspective, more and more startups and scale-ups that I talk to have to repeat the process 40-odd times for the ICBs, hundreds of times for the NHS trusts that they're trying to adopt. And they say this is crippling them. They can't get revenue because they can't get into NHS because they have to do everything 50 times and it delays revenue coming in. How can we increase the accessibility and simplicity for them to get into organisations?
If I start that one, you're absolutely right. I think any supplier trying to get into the NHS is brave and requires an awful lot of patience and resilience, I think it's fair to say. I think for me there are a couple of things. One is nationally we recognise that this is a problem, and what we're seeing is in different regions in the country, regional directors and people like Max taking the lead to try and get established pilots that work such that they can be picked up by the national team and rolled out. Only this month we are, as a national team, rolling out a patient pathway that was first developed in Somerset. So it does happen, it is happening, that is the plan. it's not easy and it takes time. And I shy away as a trust chief exec from saying, why don't we just do it all nationally, even though I work nationally? Because I think that would take even longer. So I think we don't get the balance right very often, but I do think we have to keep the two horse approach going.
So I remember about 5 years ago going to one of the NHS England testbed events, and Simon Stevens standing up at the front of the audience doing his introductory speech and saying the NHS has more pilots than British Airways, and I think he got it about right. One of the things that I think the ICBs can do is be deliberate in the way that we encourage people to commission services from suppliers with the expectation, if it meets the success criteria, of rollout and adoption across an ICB. So to Joe's point, there are way too many pilots that we start without before and after benefits management, without the expectation and the plan and the business case to then roll that out as a standardized process or a standardized tool across the system. So I think there's a commissioning and purchasing responsibility that we should have so that suppliers find a consistent buyer. The other thing I would say on the AI front, though, is that it does offer some special challenges. So if you think of yourself as a regulator, then when you assess the accuracy or bias centrally once, when you come to implement that in each individual organization, the data will be different. The challenges that presents in the implementation of the tool may be different. And then over time, that accuracy and bias may shift, and that may be different as well. So I think, Tim, underneath this is a need for us to be consistent in the way that we commission things and the expectation of rollout and adoption so that suppliers have a reasonable return on investment for the effort that they put in. But also we have to recognize that AI comes with a few special features that mean we as a buyer have to take responsibility for the ongoing monitoring and management of those in the live environment. After all, if AI changes your behavior, and it probably should, if it changes your behavior, the data you record from now on will be different. That means when the AI is applied, it's getting a different shape data than it was when it was trained. So there are some special features in there, but generally we should commission with the intent of rollout.
Thank you. And one last question. Perfect, thank you.
Hi, Jamie here from Avagen. We do outpatient management solutions, and one of the interesting things that we found recently with NHS Trust is they've been keen to work with us, but the internal project managers of the NHS are so overwhelmed with going through all of these applications, deciding, getting the buy-in, etc., that actually they've gone like, either how can you help make that a lot easier, how can we use, I don't know, privacy impact assessments from previous projects, etc. And that's something that now that we're in quite a few trusts, that's made it easier. But I think the question would be is, how do we equip NHS project managers, or how do we equip the NHS to be able to actually handle all of these innovators who want to work with the NHS? And actually, because I know onboarding an individual clinic takes a lot of work internally as well, and a lot of management of that, and it's difficult to do as an external person. So how do we get better project managers? How do we equip them with the tools to actually drive that innovation?
If we look at some of the successful programs that have been rolled out nationally, so the patient portals is a good example of where we've got 82% of all acute trusts now live and connected through the NHS app, and we're just starting out on the community mental health ones. That came with a requirement for not just the CapEx but the revenue as well to enable program management to support the rollout. One of the things that I would urge suppliers to do is recognize that there isn't that capacity in the day job to automatically take some new product and roll it out, even if it is going to deliver benefits in the future, and to have as part of the program that support for implementation. There are too many technologies around the NHS that have been implemented to a marginal extent, not a full extent, which is why when people say to me, what are you doing on the NHS app for the remainder of this year, probably for the next 6-9 months, the vast majority of it is around rolling out implementation and getting better adoption. So it's not all about new tech, it is about making sure the tech that we've got is properly implemented. So I think it is make sure that as part of the program you get appropriate program management support.
And I suppose the other thing I'd add to that is about prioritisation of funding. So I would say in my dealings with health and local government are more innovative. And I think that's because they recognise the imperative to change. They won't get bailed out, they go bankrupt. They have to change the citizen interaction model. They have to change the way their IT systems work. They have to change their business processes. And I think we in health are not yet at that level of everybody having a uniform opinion that we cannot simply continue as we are. So I don't see the same level of innovation and adoption. If we think, for example, of EHCP processes in local government and their adoption of generative AI, they're all in for it because they're in difficult places in terms of their backlog, and they're open to the transformational capability that brings. Healthcare is not as easy to work with, and I think we've got to think about boosting our innovation and improvement skills within the NHS to be able to take advantage of it.
Thank you, and thank you both. That's a good place to end today. So thank you, Max, and thank you, Joe. Thank you.